So again, good afternoon, everyone. Thank you so much for joining us today. We're very grateful to be able to give this presentation. I know a lot of us probably had issues with power and Wi-Fi. The weather was just so crazy last week. So I hope that you're all safe and warm, and we're so glad that you were able to join us today for this presentation. My name is Kayla Rogers, and I'm an Education and Outreach Coordinator for the Women's Fund. For those of you who are not familiar with the Women's Fund, we are a not-for-profit organization in Houston, and our mission is to provide women and girls with the tools that they need to be advocates for their health. So we do this through focused seminars like today's presentation, as well as curriculum-based classes and publications. All of our services are free. I highly encourage you to visit our website to see upcoming events that we have, as well as download free PDF versions of our publications. You can also fill out a request form for physical copies as well. So just to go over the housekeeping again, if you could put yourself on mute throughout the presentation, that way we can limit the number of distractions. And at the end, we will have a few minutes for question and answer. So you can put those questions in the chat at any point throughout the presentation, or at the end, I will open up the floor and you can unmute yourself to ask any questions that you have if you're more comfortable doing it that way. Okay, so today we are very fortunate to have Dr. George Adeshino here. He is going to be giving a presentation over Keep Your Ticker Ticking. And I have worked with him before. He is a wonderful presenter, so this is definitely a great opportunity, and I'm really looking forward to this presentation. So just to introduce you to the doctor, Dr. Adeshino earned his medical degree in 2011 at the University of Texas Medical Branch at Galveston. After completing his residency in 2014, he began a fellowship program in cardiovascular diseases at Baylor University Medical Center, Dallas, which he completed in 2017, including a year as Chief Cardiology Fellow from 2016 to 2017. Prior to joining Kelsey-Seybold in 2018, Dr. Adeshino served as Assistant Professor of Internal Medicine, General Adult Cardiologist at the University of Texas Medical Branch at Galveston. Dr. Adeshino is a Fellow of the American College of Cardiology and a member of the American Heart Association, American Medical Association, Texas Medical Association, and Alpha Pi Alpha Fraternity. He enjoys traveling, international cuisine, exercising, and spending time with his family. His guilty pleasure is binge watching reality TV with his wife after a hard day. So Dr. Adeshino, we are so looking forward to this presentation, and I am going to go ahead and turn the floor over to you at this point.
There we go. Can you guys hear me okay?
Yes.
Yes.
Perfect. Thank you. So good afternoon. So my name is Dr. George Adeshino. I'm a general cardiologist here at Kelsey-Seybold Clinic. I do want to say thank you so much to the Women's Fund for having me again back for this awesome lecture series. It's something that I've looked forward to for the past 3 years. I'm very sad we can't all be together in the same place like we usually do, but hopefully we'll have more opportunities for that in the future. Today we'll be talking about one of my favorite topics, which is cardiovascular disease. We'll be talking about treatment, but most importantly, prevention. And hopefully we'll have some time at the end so I can make sure I get to some questions so we can jump right into the presentation. So next slide, please. Good, so let's First, let's start off with understanding what our risk factors are. Next slide. So when we talk about risk factors for heart disease, we can kind of separate these into two different categories. There's things that we can control, which are our modifiable risk factors, and things we can't control. So things we can't control, this is things like our age. So usually above the age 65 is when we start seeing the risk for heart disease start to increase. Other risk factors that we can't control, these are kind of other things that you've kind of been born with. So just the cards that you've been dealt. So like your gender, for example. So men overall, on average, tend to have a higher risk of cardiovascular disease compared to women. Our family history also is very important. So understanding your family genetics or different cardiovascular risk factors or syndromes that might run in your family, those are very important to talk to your doctor to kind of understand what your overall risks are, as well as your previous risk of having a heart attack or stroke. We do know that patients who've had a previous heart attack or neurological event are at a higher risk to have those events later on in life as well as our race and ethnicity. And so on average, we see that our white Americans tend to have less chances of dying of cardiovascular disease. And we're gonna dive in that a little bit deeper in a couple of minutes or so. Now, the factors or the things that we can control, these are our modifiable risk factors. So these are things like your high blood pressure, cholesterol, diabetes, smoking, exercise, and as well as our weight. And these are the things that we as providers, we are going to concentrate on, because if we eliminate or control, this can vastly increase or decrease the chances of you having cardiovascular disease. Next slide, please. So if we look at medicine as a whole across the board, there usually are racial and ethnic disparities when you break it down per race and ethnicity, and heart disease is no different. Especially with it being the leading cause of death in the United States. So if we look at our white Americans, usually the risk of having heart disease is about 11.5%. And if you kind of go back to 1999 up to 2017, that is actually kind of steadily decreasing, which is good news. Now, then we haven't really seen that same trend in other populations. So in our non-Hispanic Black adults, we tend to see this in about 9.5% of that community, 7.4% in our Hispanic communities, and 6% in our Asian communities. Unfortunately, Black Americans are at 2 times higher risk of having mortality from heart disease. So even though in the broader scheme of things, the overall prevalence might be lower, they have an increased risk of actually passing away from cardiovascular disease. Next slide, please. So when we break it down even further to different risk factors, so first looking at hypertension. So if we look at the numbers here, African Americans are almost 1.5 more times likely to have elevated high blood pressure compared to other populations. And this is very important because, as we know, hypertension is known as the silent killer. So a lot of people will walk around with blood pressures in the 180s, 200s, almost stroke level and heart attack range blood pressure, but they won't necessarily feel those symptoms. And so it's not until they go to a doctor and get checked out that even gets picked up. There was actually a study that was done, and only about 24% of all patients who have high blood pressure actually have controlled blood pressure. And this is really important because when blood pressure goes unchecked for a long time, it actually causes chronic damage to our arteries as well as our end organs. And so it can cause heart attacks. It can cause strokes if it's affecting the arteries of the brain. If it's affecting the eyes, the arteries in the eyes, it can cause blindness. And for a lot of our Black and brown communities, this is one of the major reasons why they have kidney disease and requiring dialysis. So keeping our blood pressure under check is very, very important. Obesity as well. As you can see by the graph here on the right, our Black and brown communities, again, have a higher risk of having obesity, which further increases their risk of having cardiovascular disease as well. Next slide, please. Same thing when it comes to diabetes. If we look, the Hispanic community actually has a little higher association with having higher rates of diabetes, with our Black communities being almost right after. So again, the Black and brown communities being very highly hit by diabetes. This is extremely important because about 50% of all patients who have diabetes will then develop having some type of cardiovascular disease later on in life. We actually refer to diabetes as a coronary artery equivalent. So it's almost like we're assuming that everyone who has diabetes has some form of cardiovascular disease because there's a very high prevalence. So making sure your sugars are under control and making sure you're working with your doctor to get your diabetes in check and to prevent those who don't have diabetes from developing it is very important. Now, when it comes to high cholesterol, the numbers seem to be a little even across the board when we're looking at all of our communities on this the slide here on the right. So it's about even with all of our communities, but again, having uncontrolled high cholesterol as well increases your chance of you having cardiovascular disease. Next slide, please. So heart disease can come in many different forms. It's kind of, I kind of think of heart disease as being an umbrella type of term, and we can kind of break it down further and talk about these in more detail. Next slide, please. So coronary artery disease, or CAD, is probably the most common or the most popular heart disease that people know about, because this is what causes heart attacks. So your coronary, your heart, the major function of the heart is to pump oxygen-rich blood to all of your vital organs throughout your system. But your coronary arteries are the arteries that actually feed the heart muscle itself. So it's really important that those arteries stay healthy so they can provide the actual heart muscle itself with the blood and the oxygen that it needs to, function properly. So if you look at the pictures here on the right, these are all pictures of coronary arteries. And kind of imagine it's like someone took an artery, laid it down on a chopping board and kind of sliced it. So these are kind of small cross sections. So that picture on the very top, that's what a normal or healthy coronary artery looks like. So as you can see in the middle, there's no obstruction, there's no plaque, it's wide open, which allows blood to kind of get to where it needs to be to allow the heart to kind of do its job. Now, if you look at the picture on the right, this is what happens when you have extra fat circulating in your blood system. What happens is these fatty-like substances, they form or they adhere to the walls of your vessels, and this causes these plaque deposits. And you can kind of see that in that middle picture at the bottom around 6 o'clock, that blue and pink stuff. You see how much it's obstructing that lumen. So that opening that we saw in the top picture, you saw how nicely wide open it is. That opening is already starting to decrease. So it's decreasing the amount of blood flow that's able to get to the heart tissue and the heart muscle. Now, a heart attack happens when this plaque formation becomes unstable and a portion of it goes into the lumen. Our body, for some reason, responds with an inflammatory response, and it causes a clot to form. So that clot formation completely shuts off the artery and it completely blocks it. So this is what happens when you have a heart attack. And so it's important to kind of keep this cascade in mind as we go throughout our talk. Next slide, please. So the process to have a heart attack in regards to plaque formation is similar in men and women, but there are subtle differences anatomically that really can cause vast differences in treatments and symptoms and such. So if you look at the picture on the top right here, that's what an anatomical heart looks like. So if we compare a woman's heart to a man's heart, in general, women's hearts tend to be smaller and the chambers themselves tend to be smaller as well. The walls in between the chambers also tend to be thinner as well. And in general, a woman's heart actually pumps faster than a man's heart, but it only ejects about 10% less blood with each squeeze. So it's pumping faster, but it's actually pumping less blood with each pump that it's doing. We also know that men and women tend to respond differently to stress. And initially we thought this was just emotionally, but there's actually a more physiologic difference as well too. So when a woman becomes stressed, her heart rate actually increases and her heart tries to eject more blood, versus when a man gets stressed, their arteries in their heart tend to constrict, and this actually raises their blood pressure. So these differences, I mean, we actually can see this clinically. A lot of our patients who come into the office, the number one kind of symptom that I see a lot of the times, women coming in complaining of palpitations, and that's the number one reason. So at baseline, their heart rates are already going pretty fast, but when you add that increased stress or increased anxiety, that causes the heart rate to go up even faster. So that's also important, and we'll talk about why that's important a little bit later. Next slide, please. So coronary heart disease is very, very different in women. So I want you to look at this picture on the right here. So this is kind of what your cardiovascular system looks like. So most people are born with 3 arteries that supply the heart muscle. There's one large one on the right, your right coronary artery. And then on the left, you have a left main that kind of splits off into 2. One is called your circumflex artery, and the other is your left anterior descending artery. Now, in men, most of the time, those heart blockages kind of are in those big arteries that I just kind of talked about. But As we kind of look at the rest of the picture, those arteries tend to branch and get smaller and smaller until we kind of get to a molecular level. And that's actually where women tend to have their heart disease. So if I send a patient for an angiogram and look at if they have any heart blockages, you can easily see if there's any blockages in those main arteries. So kind of think of that like being the highways of the road. They're bigger. We're able to put in stents if there's any obstruction. But if those little side branches that we're seeing, think of those kind of like the feeder. Those feeder roads, that's where women tend to have heart disease. It's harder to see one in an angiogram, and those arteries are usually smaller, so really can't put stents in that either. So it makes that harder to not only diagnose, but also harder to treat. Heart attacks in general, there's some evidence that anecdotally that, heart attacks are a little bit more harder on women, and that women require longer hospital stays, and they're actually more likely to die while in the hospital compared to men. I don't think this is, there's a lot of papers that have talked about this, and it's clearly not anything against the strength of women, because if you ask me, I think women are stronger than men in general anyway. But I think a lot of the times women end up getting misdiagnosed, and that lag of time of diagnosis is critical. And I think that's what's causing these disparities between men and women quite a bit. We've also seen there's multiple medications that we know that have been studied that if taken after a heart attack can decrease the chance of you having an additional heart attack, but also decrease the chances of you dying from a heart attack. And there's been studies that actually show that women tend to get discharged from the hospital without all of these life-saving medications. I'm not really sure why that is, but that is another thing that we've been seeing, a very big disparity between the treatment of men and women. In general, women also tend to have their heart disease when they're older as well compared to men. So we usually see heart disease starting to creep up in men around age 66 versus women around age 70 or so. Next slide, please. Now, we believe that lag of heart disease in women around age 70, we think there's a hormonal component to it. So if you look, estrogen actually has an effect on almost every single tissue and cell in our bodies. And this is the same when it comes to our heart as well as our blood vessels. So we think that estrogen is actually believed to have a positive effect on the inner layer of artery walls, and it kind of helps to keep the blood vessels flexible. So if you remember that picture I showed earlier, that coronary artery with all that gunk and all that plaque being formed, that can cause the artery to become very, very hardened. And that's what atherosclerosis essentially is. But estrogen tends to be a protective quality, and it keeps that artery nice and flexible. So when a woman undergoes menopause, there's a sharp decline of the natural production of estrogen. And we think that is what's causing this increased risk of heart disease postmenopausal. So they have an increased risk of heart disease. And we also tend to see that their cholesterol starts to become elevated as well. And there's also actually a direct link with heart palpitations as well. So we talked about, in general, women's hearts tend to relate to stress by increasing the heart rate. There is some evidence that when that estrogen production decreases, there's a direct correlation with an increase in palpitations, which can lead in a further increase in their resting heart rate, more palpitations, and also non-threatening arrhythmias. So just that baseline, that can just cause an increased workload of the heart as well. Next slide, please. So other heart presentations that affect women primarily include Prinzmetal variant angina, which is also known as vasospasms. And so essentially this is chronic chest pain that's being occurred by coronary arteries that are spasming out of control. So if you look at the picture on the right here, so there is a lining or endothelium of all of our arteries, and there's a muscular component to it. So like every other muscle in our body, it can constrict and it can also relax. These vasospasms happen because it's sometimes when patients are exposed to cold, if they're exposed to stimulant medications like cocaine or amphetamines, tobacco abuse can also cause this, and extreme emotional stress. And these arteries clamp down. And as you can see in that picture on the right, it can completely obstruct blood flow. So this can actually mimic symptoms and signs of a heart attack. It can happen in men, but we primarily tend to see this in women. And for some reason, it tends to occur either late at night or early in the morning. So that's usually around the time in the ER we start seeing patients with vasospasms. We think there might also be a hormonal component that happens as well too, but the exact etiology is not really known. The important thing is that, again, it can mimic a heart attack, but with the proper medications, this can actually be prevented and successfully treated. Next slide, please. Another presentation of heart disease that uniquely affects women is postpartum cardiomyopathy. And essentially, this is newly diagnosed heart failure that develops in the third trimester of pregnancy or within the first 5 months of delivering their baby. And so essentially, they just go into this acute phase of heart failure. Normally, your heart should be able to pump about 55% of all the blood that comes in it. Should be able to pump about 55 to 60% out. But with postpartum cardiomyopathy, that pumping function becomes very faulty and it drops usually below 45%. It can range from a mild presentation, so a pumping function like in the 40s, but we've also actually seen severe cases when it's going down to 20%, and these patients are in actual fulminant heart failure. With medications, a lot of these patients will tend to get better, but we have seen patients not recover their pumping function and actually require heart transplants. So it's rare, but this is something that we also have to kind of keep in consideration. Next slide, please. So we tend to see it in about 1,000 to 1,300 women in the United States per year. There is a strong connection with the African American community, and we do think there's a genetic component that's causing this. It can sometimes be difficult to treat, and that's mainly because some of the heart failure-like symptoms are some of the same symptoms that you have in pregnancy. So having extreme fatigue, increased nighttime urination, shortness of breath, swelling in the legs, low blood pressure. There's a lot of crosstalk, so you can just see that in a normal pregnancy. But usually these symptoms are very extreme and they're very acute. Unfortunately, again, women tend to go to the ER complaining of these symptoms, and there tends to be a lag of diagnosis because, again, these symptoms are being written off as something that's a variant of normal. So sometimes this is difficult to catch, but the clinching the diagnosis is getting an ultrasound of the heart and confirming that faulty pumping function for women. Women who do have a history of postpartum cardiomyopathy have a very high risk of developing it again in subsequent pregnancies. So we usually tend to tell women not to get pregnant a second time if they do have it. But I have seen cases of some of my patients who have had successful pregnancies after, but the risk of them having severe heart failure as well as mortality goes up quite a bit. So that's something we have to definitely keep in mind. Next slide, please. Now, of course, as we know, we're in the pandemic. It's been a year since COVID has been around, which sounds, crazy to even say that out loud. So I'd be remiss if we don't kind of talk about the effects of COVID-19 with the heart. So I kind of want to briefly touch about some of the manifestations that we've seen, and especially some of the gender differences that we've been seeing as well. So in total, women usually account for more of the confirmed cases of COVID-19, but for some reason, we're seeing that women actually have less severe disease. They're in the ICU less often. They're less likely to require mechanical ventilation, and they're actually less likely to even die from COVID-19. There's multiple theories as to why women seem to have a protective factor. Some of the science is proving that a lot of your immune response might be tied to your X chromosome. And so for women being XX, having 2 of those chromosomes might give some type of protective factor. But I think lifestyle choices and modifiable risk factors are also important as well. And so a lot of men tend to have a lot of the pre-existing conditions that give them that increased risk of having a very severe COVID-19 infection versus women. Some examples include diabetes. So at baseline, diabetes suppresses your immune system. So that would make it very difficult for someone who has diabetes to be able to actively fight off COVID-19. In our patients who smoke or have asthma or COPD, again, that can cause some baseline weakening and damage of the lungs already. So then if you add on COVID-19 pneumonia on top of that, you can kind of see how that would be difficult for the lungs to overcome that. But then also having baseline heart disease like coronary artery disease or even heart failure. Having these makes it very difficult for your body to withstand the stress of the illness from, the effects of having a fever, your low oxygen levels, as well as unstable blood pressure. And then just having poor metabolic health in general, being sedentary, being pre-diabetic or obese, that we've actually seen that there might be some type of cross reactivity with that increase in your risk of having a drastic inflammatory response, which can increase the risk of you developing blood clots as well. So I think with women, there probably is a genetic component, but also women tend to have better lifestyle choices than men. And that seems to have had a very protective mechanism when it comes to COVID-19 in the heart. Next slide. So how does COVID-19 actually affect the heart? It's very difficult. In general, we think that there's two possible hypotheses. One, we think the virus might directly invade or inflame the heart muscle. And two, when COVID-19 affects the lungs, it's decreasing the body's natural oxygen supply. And so you can kind of think when your body's sick, it's going to require a lot of energy and a lot of oxygen, but your lungs is not really providing your body with that. So there's a big mismatch between the oxygen supply and the oxygen demand. And that greatly can affect the heart from being able to pump efficiently. Now, when patients come in with heart issues or heart failure or a heart attack, there's an enzyme that we usually measure in the bloodstream called troponin. And this directly kind of correlates with any heart damage at all. What we've been seeing in our patients who are admitted to the hospital who have COVID-19 is that about 25% of these patients will have elevations of this troponin. Even if there's no evidence of any overt heart dysfunction at all, 25% of them at baseline will have these elevations of troponin. Now, the surprising part is only about 1/3 of these patients will actually have a pre-existing cardiovascular disease. So that other 2/3 might be young and healthy patients who have never had a heart issue prior, but they're still having, some of the most high troponin levels I've ever seen while practicing. I actually had I think she was 32-year-old marathon runner, completely healthy, got a really bad case of COVID-19. Her troponin levels, normal is like 0.1. Her levels were in the 120s. No evidence of heart failure, no history of blockages, heart failure, or anything. So that's something that we've been studying and trying to figure out exactly how the heart is responding to this COVID-19 infection. Next slide, please. Now, the majority of people who have COVID-19 usually have mild symptoms, and most of them will recover, but there is a percentage of the population, about 20%, who will develop pneumonia in the lungs, and then about 5% will develop very severe disease. Now, COVID, the virus itself, like we know, it's definitely dangerous, but it's more so the body's immune response to it that's causing most of the issues. So normally when you have an infection, your body has this inflammatory response. It uses cytokines and things of that nature to try to help fight off the infection. What we're finding is the COVID-19 virus is actually triggering this robust inflammatory response. So we're calling it a cytokine storm. And that's what's causing the damage of multiple organs. And the heart, unfortunately, is also included in that as well. Next slide, please. So in general, again, that COVID-19 is causing this inflammatory response, and this can actually activate the body's clotting system, and it can damage the lining of your blood vessels. And so when that lining gets damaged, it decreases the chances of the vessel ability to resist clot formation. And so we tend to see clots in the heart, in the lungs, in the legs. There was one paper that I read of a patient who unfortunately succumbed to COVID-19, and on autopsy, they were looking at her lungs, and her whole entire lung was just filled with clots, even down to the small vessels. So this really triggers this clotting response that can be very dangerous for patients. You can imagine if the lungs are filled with clots, they're not going to be able to function properly either. And so again, that oxygen mismatch is going to happen, which can cause even further damage to the heart. Next slide, please. The other common thing we're seeing is myocarditis, which is inflammation of the heart muscle. And this typically initially, actually, let me back up. We initially thought that this only occurred in patients who had severe disease. What we're seeing now is patients who have clinically overt myocarditis do tend to have pretty severe COVID-19 infection. And we think that the virus is directly invading the heart itself and causing weakening of the heart muscle, which leads to transient heart failure. It can cause very dangerous arrhythmias, which can cause issues in stability of patients' blood pressure. And in certain cases, it can actually cause sudden cardiac death even after the patient recovers from COVID-19. we're actually seeing now there's studies that are showing patients who have COVID-19, they're going for a cardiac MRI to kind of evaluate the structure of the heart after recovering from COVID-19. And these cardiac MRIs are actually showing that there's scar formation as well as inflammation. So even though the patients may not have any overt clinical signs of heart damage, we're seeing that, on cardiac MRI, there is actual scientific evidence that the heart has been damaged from COVID-19. I think what's even more alarming is there's a couple of studies that are actually looking at our college athletes, since, a lot of them are playing in these isolated bubbles and tournaments and things of that nature. And one of the good things is we've been getting a lot of data because they have to get tested for COVID pretty frequently. About 10 to 13% of all of these college athletes are testing positive, after they test positive with COVID, they're actually having signs of myocarditis as well. And the reason why that's alarming is you have to think about it. As a college athlete, they're young, they're in really good shape. So the chances of them having any pre-existing heart disease is almost, zero. So these young, healthy adults are even having heart damage. What makes it even more concerning is, they're out there exerting themselves in whatever field of sports that they're playing in. And so there's that risk of sudden cardiac death that we have to worry about as well. So the information of this is pretty early, but we do need to figure out clinically what this means for patients. And is this something that we should routinely be checking on our patients as well? Next slide, please. So hopefully I didn't scare you guys too much, but I think it's important for us to really talk about how COVID-19 kind of affects the heart so you kind of know what to expect. But now that we know the different types of heart disease, the differences in men and women, let's talk about the warning signs and what we should be looking out for and when you should be alerting your doctor. Next slide, please. So as we talked about previously, there are vast differences between men and women. The structure of their heart, how their heart responds to stress and different other conditions. And this can greatly affect what type of symptoms that our patients are kind of presenting with. So in medical school and in fellowship, we're all taught the classic signs of a heart attack. So chest pain is kind of right in the middle of the chest. It might radiate to your arm or your jaw. It usually occurs with exertion. So if you're working out or doing something physically active and then gets better with rest, that's kind of what everybody recognizes as kind of the typical angina or a heart attack type pain. And now that I've said this, if you go and watch any Hollywood movie, that's exactly how it looks like in movies as well. But what we're finding out is that's actually more classic and stereotypical symptoms for men. Women can present completely differently. One, the pain doesn't even always have to be that severe. It can sometimes be a subtle dull or an ache. Instead of it radiating to the arm or the jaw, women tend to have it radiating to the back. So in between their shoulder blades is kind of the most common thing we see. In addition to having shortness of breath and nausea and vomiting. Additionally, women sometimes tend to faint, have indigestion. And I think the biggest thing that I'm starting to recognize is extreme fatigue. Now, this is an issue because as we know, women are like the backbone of every facet of our society, and they tend to be the caregivers for everybody else. And a lot of the times they don't even think about their own fatigue because they're busy, taking care of everybody else and handling business and, managing life as it comes to them. But now I'm asking a lot of my female patients after they've had their heart attack, and a large percentage of them are saying, you know what, around the time this happened, right before, I felt this extreme amount of fatigue. So that's something that's, whenever I hear that, a light bulb kind of goes off, and that's something that we as providers need to start paying more attention to. But looking at some of the constellation of these symptoms and recognizing the difference between men and women, it's really important. You want to make sure that you're seeking medical attention whenever you get this constellation of symptoms as well. Next slide, please. Now, again, I'm a cardiologist, so of course I like to talk about treatment, but more importantly, I like to talk about prevention. So of course, I'm going to treat your heart disease if you come to my office and have cardiovascular disease, but my main job is I want to prevent you from even developing heart disease. So how do we do that? One of the biggest things is you have to know your statistics, so you have to know your numbers. Next slide, please. So kind of a quick, I always think about it, we tend to take our cars to get maintenance, and, when you go there, the mechanic gives you a printout of, things that need to be fixed, things that are faulty, things that might need fixing in the near future. That's kind of the same thing that we're doing as doctors, especially when it comes to modifiable risk factors that can decrease the chances of you having coronary artery disease. So ideally, adults should be getting their cholesterol checked every year with their physical, and a little bit more frequently if you have elevated cholesterol. In general, we want to keep that total cholesterol below 200. Your bad cholesterol or your LDL, we want to keep that at 100. And in more, risky patients who might have had a history of heart attacks in the past or strokes, and even our diabetics, we actually want to get a little strict with that and actually get that closer to 70. For your blood pressure, again, this is the silent killer. So if you're not getting your blood pressure checked because you don't have any symptoms, this might go unchecked for a long time. But ideally, you want to keep your cholesterol below 120 over 80. So remember I said in multiple studies, it's shown that only 20 to 25% of patients who have high blood pressure will actually have it controlled. So again, that uncontrolled blood pressure can be causing silent damage to a lot of your organs. So it's very important to get that under check. For our patients, fasting blood sugar, we want to keep that at 100. Usually with your physical, your primary care provider will usually check what we call a hemoglobin A1C, which is a 3-month average of what your blood sugars have been. The kind of cutoffs is pre-diabetic is when you get above 5.5, and then overt diabetes is once you get to 6.5. So we really want to keep, patients who don't have diabetes, we want to keep you below 6.5, actually below 5.5 if possible. And our patients who do have diabetes, below 7 is considered control. Again, diabetes is highly, highly linked. It's a coronary artery equivalent. So we really want to make sure we can prevent that if we can, and or controlling it if you do already have the diagnosis. And lastly is our weight, which is, of course, this is a tough subject because with the pandemic, I think I read an article that the average American has gained 15 to 30 pounds throughout this year. But you really want to make sure we're keeping our weight under check as well, too. So you can talk with your doctor about calculating your BMI or your body mass index. And this is what's going to kind of tell you what your ideal body weight should be for your height. Over 25 is considered overweight. And then once you get towards 30, it's considered obese. So we want to keep you down below 24. Of course, it's a calculation. It's not perfect for everybody's body type. So also doing a hip to waist ratio can help as well, too. Next slide, please. Now, we've talked about mental health quite a bit, physical health, but our mental health is actually equally important. And especially in these very trying times, this is very paramount that we're paying as much attention to our mental health as we are to our physical health. And that's because there is a direct link with our mental health and cardiovascular issues. Next slide, please. One of the presentations is also known as broken heart syndrome or Takotsubo cardiomyopathy. And essentially, this occurs after having like a traumatic life event. So like the death of a loved one, physical injury, or strong emotional response to something, it triggers this cascade of heart damage. And essentially, your body releases this surge of adrenaline and other stress hormones, and it kind of causes the heart to go into transient heart failure. And these symptoms are severe enough where they can mimic a heart attack and heart failure. So patients are arriving to the ER. They have their blood tests look like they're having a heart attack. Their EKG looks like they're having a heart attack. We look at an ultrasound of their heart, and there's a portion of their heart that's not pumping as well as we would like it to. But then when we take them for an angiogram, there's absolutely no blockages at all. So it's not caused by having overt blockages, but it's triggered from this uncontrolled stress or stress response. And so the bad news is it can be pretty severe. And I mean, patients can actually pass away from this. But if it's caught quickly and treated with medication, in most patients, this is actually treatable and can resolve on its own. But this is an example of why we need to make sure we're keeping our mental health under check as well, too. Next slide, please. And if you think about the pandemic, I mean, this has been a very trying times for all of us. People are, suffering the loss of their loved ones. They're isolated from the people that they love. People are losing their jobs. And just having the fear of COVID-19 in general can be definitely draining on your mental health. And if you haven't had a previous history of it, it's definitely exacerbating people who've had existing diagnoses. In addition, we're actually learning that COVID-19 can cause some lingering effects, so some complications, neurological, mental complications such as delirium, agitation, and even like stroke-like symptoms. So if you have existing mental or neurological or substance disorders and you get COVID, it actually increases your risk of you having severe outcomes as well. So again, making sure that we're paying attention to our mental health is paramount. Next slide, please. And so we've known that there's been a connection between the head and the heart. They've actually have studies that have shown that about up to 45% of patients who have had coronary artery disease, specifically those who have had a heart attack, tend to be diagnosed with some form of depression or anxiety afterwards. So again, making sure you're embracing self-care, making sure you're taking care of yourself from a mental standpoint is very important, and making sure you're seeking help as well too is very important as well. Next slide, please. Now, tip number, I mean, this is pretty self-explanatory. Stop smoking. All of my patients will definitely attest to you. All of my smokers, probably the first question is, how have you been since the last time I saw you? And the second question is, are you still smoking? And that's because smoking is one of the most important modifiable risk factors when it comes to coronary artery disease. Next slide, please. So smoking has actually caused almost close to 500,000 deaths each year in the United States. And so smoking alone by itself, not even if you have any other risk factors, it triples your risk of heart disease, in addition to it increasing your risk of having a stroke, of having multiple cancers, and many other different disorders. And what we're learning, secondhand smoke is pretty bad as well too, because it actually increases your risk in non-smokers who are exposed to secondhand smoke chronically to up to 20 to 25%. So I actually have a couple, and the wife unfortunately is a chronic smoker, and her husband has not smoked a day in his life. And other than that, he's a pretty healthy guy, and they both have heart disease that looks pretty significant to someone who smoked their whole life. So just him being around that secondhand smoke has caused him to have heart disease as well. A lot of people, smoking is very addicting. Of course, it becomes part of your lifestyle, and people get discouraged, I think, to quit to smoke because they're like, you know what, what's the point? I've been smoking for 50 years. But studies have actually shown that when a smoker stops smoking, their risk of heart disease, it actually starts to drop immediately. And if they've stopped smoking for about 10 years, that risk actually goes down to the risk of someone who has not smoked. So it can drastically decrease the progression of any disease they might have, and possibly prevent the formation of any future disease. So stopping smoking is paramount. Next slide, please. Now, a lot of the times we get asked if vaping is a better choice than smoking cigarettes. Unfortunately, there's not a lot of studies on this in regards to the cardiovascular effects. So we're still probably waiting for more studies to be done. What we do know is vaping tends to have less toxic chemicals that are associated with cigarettes, but it can cause severe drastic lung damage, and actually has an increased amount of nicotine. So a lot of patients will try to transition from smoking a cigarette to vaping, and hopefully, thinking that's going to help them stop smoking. But actually, vaping might be a little bit more addictive than smoking regular cigarettes as well. So it's still not the best thing to do either. And, preliminary studies have shown that young adults who have smoked, especially vaping, actually end up having a higher risk of having severe COVID-19 infections, worsening pneumonia, and just overall increased complications. So we know smoking for sure is not bad. Excuse me, we know smoking is bad. We're not sure how bad vaping is, but it's probably not the best thing for your heart and lungs either. Next slide, please. Now, one of the other tips to kind of help prevent heart disease is just to maintain a healthy diet. This is also hard because with the pandemic, everyone was home for a long amount of time, and we were all probably mindlessly snacking as well. But keeping a healthy diet is something that can drastically decrease the risk of you having heart disease. Next slide, please. And, as we know, there are so many fad diets that, or restrictive diets that people tend to do. I always tell people, try to start off with very small changes and do something that you can consistently do. And so these are some easy tips that you can kind of do. So portion size is key. So we all know if you go out to eat in Texas, they give you enough food to probably feed 3 people for 3 different days. But cutting down your portion size is an easy way to decrease your calorie intake. You also want to try to eat more fruits and vegetables. So I always try to recommend patients look at your plate, and half of it should be nothing but leafy green vegetables or fruits, with a quarter of a lean meat and then a quarter of healthy grains. You want to try to avoid fast foods, processed foods, and sugary snacks. Limit unhealthy fats as much as possible, and definitely reduce your salt intake as well. So just making these small little changes here and there will definitely go a long way. And especially, I tell people soda in particular. I've had patients stop drinking soda and lose 5 to 10 pounds just from stopping that, just from decreasing their sugar intake. So just making these small changes here and there can greatly decrease and have an overall effect on your health. Next slide, please. Now, exercise. So this is something that I personally do not like to do, but something that we all know we have to do. Next slide, please. Now, exercising can greatly affect your cardiovascular health. So the American Heart Association actually recommends that adults get around 150 minutes of cardiovascular exercise per week. And so when we say cardiovascular exercise, we want to do something that's going to increase your heart rate for around 20 to 30 minutes. So, walking is good. I always tell patients, you don't have to go do a marathon or train for the Olympics. Again, you want to do something that you can do, that you enjoy doing, and something that's sustainable. So I always say, make it a lifestyle change. Don't think of it as a chore or something that you have to do. Try to find a way to incorporate in your daily life so it's something that you actually look forward to. And of course, if you lose weight, that actually reduces the burden of your heart, your lungs, your blood vessels, your skeleton, and it just allows your body to work more efficiently. So it's really important. Next slide, please. And lastly, patients have been asking us, how do I prevent COVID heart complications? And essentially the answer is you want to try to decrease the chances of you getting COVID. Next slide. So in this standpoint, we want to make sure that we're working with the CDC recommendations. So making sure you're wearing your mask when you're out, sticking with your hand hygiene, so washing your hands pretty frequently throughout the day. Make sure you're maintaining social distancing rules, so staying 6 feet away, avoiding crowds and gatherings, which I think for all of us has probably been the hardest. Just a quick story. I was on call New Year's Eve, and actually saw an 88-year-old great-grandmother who went to a Christmas party with her family. And it was about 15 to 20 people of just their immediate family that was present. And all 15 to 20 of them got COVID. 10 of them ended up in the hospital, and 2 of them ended up passing away. So, of course, we want to see our loved ones. We want to socialize, but being in a crowd, being in gatherings, being around that many people is going to increase the chances of infection being spread. So we really need to avoid crowds and gatherings, and try to avoid traveling if possible. I know some people have to travel for family or for work, but leisure travel, try to decrease it if possible. And if you are, try to do things that are isolated. So, a lot of my patients have been going like camping or riding in their RV or driving cross country, things that allow them to isolate from other people. But you definitely want to be careful for leisurely travel, especially in airplanes. And if you do meet the criteria and you have the capability, getting the vaccine as well too. I know that's a little controversial, so that's something that everyone has to make a personal choice on their own. But I think it's important that we talk about that as well. Next slide, please. And I believe that actually concludes our presentation today. We can open the floor for some questions, and I can hopefully help get some questions and comments or any clarifications if needed.
Okay, thank you so much for that wonderful presentation. I know all of the stuff about COVID and the heart was very interesting to me because I haven't really seen anything on that yet. So that was really interesting. We are going to go ahead and open up the floor. If you have any questions, you can feel free to put them in the chat. Or I know sometimes you may have a long-winded question, or maybe you're just not confident with how fast you can type. So if you would like to unmute yourself to ask your question, you can do that as well. So I have the chat box up here, but I will go ahead and kick off with a question.
Yes, ma'am.
So you talked about family history a bit.
Mhm.
Is there any specific tests other than those things that come along with our normal annual exams to check our blood sugar, our cholesterol, and our blood pressure? Are there any other specific tests that someone should do if they have a family history of heart disease?
So not necessarily, unless there's a specific syndrome that runs into the family. For example, there's something called familial hypercholesterolemia, where patients have very elevated cholesterol levels at a very young age. There's genetic tests that we can run for that. For other cardiomyopathies like hypertrophic cardiomyopathy, there's also genetic tests for that as well too. We usually don't recommend doing that just as a baseline, so there needs to be a clinical indication for it and some presence of some type of syndrome within their family in order to get that done.
Okay, thank you. Okay, so another question that I have here, this was actually a question that was brought up in a previous heart health presentation that we did, but I thought it was interesting, so I figured I would ask again.
Sure.
So you talked about, when you talked about nutrition and a diet, you talked about the importance of a lower sodium diet. Do all types of salt count? Is there any difference with sea salt or Himalayan salt, regular table salt, or is it all just salt?
In general, yeah, it's probably not the best for you just because, especially in our Black and Brown communities, we tend to hang on to salt. And the more salt you hang on to, it actually increases your blood volume, which would increase your blood pressure. And in patients who have heart failure, it can actually cause them to go into a heart failure exacerbation. So, salt in general, it's a good rule to try to keep it below 2 grams if possible. And our heart failure patients or those who have high blood pressure, trying to keep it below 1500. There does have probably need to be more studies on it. I think the Himalayan and the sea salt might be a little bit more healthy than the synthetic salt that gets made, but it's probably all probably likely going to have the same effects.
Okay. So we have a question in the chat here. Is it generally recommended that women 65 and older take a daily dose of aspirin or statins due to lower levels of estrogen?
That's an excellent question. So there's actually a risk score that you can calculate, and it's called a 10-year ASCVD. And what it does is it takes into your gender, your past medical history, your blood pressure, and your cholesterol levels. And essentially, it spits out this number and it tells us what's the chances of you having a heart attack or a stroke in the next 10 years. So anyone who scores a 7.5% or above ideally should be both on a cholesterol lowering medication in addition to an aspirin. If you do not meet that criteria, then that's something that you can talk to your doctor about. I do want to make sure that everybody, before you start taking a daily aspirin, to make sure you talk to your physician as well, because of course it is a medication, so it's not completely benign. There are side effects, especially if you have like ulcers or a tendency to bleed. So you want to make sure you balance the risk versus the benefit with each treatment with your doctor before you jump into that treatment as well.
Great, that was a great question. Speaking of estrogen, you talked about it earlier in the presentation, and I wanted to know, estrogen therapy after menopause, do the risk outweigh the benefits? So if someone was wanting to take it maybe because of the links between estrogen and the and heart disease, would the risk outweigh the benefits?
So it might in regards to heart disease, but we also do know that hormone therapy can cause other issues like increasing your chances of having breast cancer, ovarian cancer. It can also sometimes be make you become hypercoagulable as well. So, being on estrogen and smoking is definitely a horrible combination as well. That's something that you're more than likely, the OB-GYN should probably make that decision. I think it probably will give you some cardiovascular benefits, but the risks seem to be pretty hefty. So it needs to be based off of a patient-patient basis.
Okay, great. Another question here about nutrition. So I actually have this conversation with my boyfriend often because I like to eat like leaner meats, like turkey meat or chicken, and he is all about steak. And so he's like, "Well, I heard recently that red meat isn't as bad for us as we previously thought it was. Is that true?"
So I'm in the school of thought as you are as well. I think the leaner the meat, the better, mainly because no matter what you eat, we're going to have circulating cholesterol levels. But if we're putting more animal fat into our bodies, it's going to increase the chances of you having it. There are some people that think we shouldn't eat any animal meat at all. I think it definitely can have great effects on your cholesterol. But again, that's a lifestyle choice that you have to balance because I think that's a pretty stringent diet to maintain. But if you are going to be eating meat, definitely trying to do more of the leaner meats, I think is the way to
Awesome. I'll make him watch this presentation.
go. Tell them to
He
call me.
can't argue with me anymore. Okay. So the next question that I have, a lot of people may be interested, especially after this presentation, in monitoring their blood pressure at home. And so if I was to go out and buy a machine over the counter, would you have any recommendations? Does it matter if it's a wrist or an arm cuff?
Yeah, so let me just start off by saying I'm not affiliated with any blood pressure cuffs. I'm saying this purely as I've done my own trial and error. There's a brand that I really like called Omicron. One, because it seems to be very accurate, and two, it's Bluetooth, so you can actually connect it to your phone. It can make a nice graph, a PDF, and so a lot of my patients will bring that in. It makes our jobs as physicians a lot easier. When you compare the wrists to the arm cuffs tend to be less accurate, mainly because we're measuring the pressure in your arteries, and of course the arteries of the wrist are a lot smaller than your arteries here in the arm, and so sometimes it makes those blood pressure readings seem to be a little bit more elevated. And so even I usually have pretty good blood pressure, but every time I go to the dentist or anywhere where they use a radial cuff or the wrist cuff, my blood pressure's through the roof. So I usually recommend getting that arm one. And then for patients who want to make sure that they are checking their blood pressure at home, I also recommend bringing it to your doctor's appointment, making sure that you can check your blood pressure with your machine, have your doctor check it, and make sure they're correlating as well too. So you want to make sure you have an accurate reading as well. And I think someone just popped in the comments saying, is it Omicron? And yes, that's the correct spelling for whoever wrote that.
Okay. No, she got it. And then other recommendations. So is there a certain time of day that it's best to check it? If you don't have hypertension, do you need to check it every single day?
I think if you don't have high blood pressure, you've had normal readings at your doctor's office, and you're above the age of 65, maybe just checking it a couple of times a week or, once a week in between doctor visits, because if it is going up, that's something that we would like to know sooner than later. If you do have high blood pressure, I usually recommend checking at least once a day. For me, I like patients to take it 1 to 2 hours after they've taken their blood pressure medication. And just make sure you're not taking it as soon as you come in from work or after a stressful event, because as you know, it's going to be higher. Make sure you're sitting down, both of your legs are separated, they're not crossed. Take a couple of deep breaths, get zen, and then check it. Sometimes too, you can tend to see there might be some differences, so you can maybe even check it more than once at one sitting to kind of see if you're getting around the same thing to make sure it's accurate.
Awesome. So the next question that I have, I used to work as a scribe a couple of years ago. And so
Nice.
A lot of patients would come in, and when they would get prescribed new medication, they were very hesitant about adding something into their regimen. I know with certain, chronic illnesses, once you're kind of good or your levels are better, sometimes you may have the option to kind of cut back on the medication. So for your diabetes, for example, or high cholesterol. But is that the same with heart disease, or does it depend? So if someone is diagnosed with heart disease, they're started on medication for it, is that something that they're going to have to take for the rest of their life?
So the rule of thumb to decrease mortality and to make sure that we're decreasing the progression of heart disease, if you have been diagnosed with heart blockages, at least being on an aspirin and something to control your cholesterol, that's usually lifelong. And those two medications will help decrease the chances of that plaque formation that you have from getting worse. When it comes to if you've had a heart attack, there are certain medications that we would like for you to stay on for at least 1 to 5 years, because again, studies have shown that it decreases your mortality. But if it's just, run of the mill, high cholesterol, high blood pressure, those things are sometimes negotiable, especially if patients, I've had one patient, she lost 40 pounds and came off of everything. So there are definitely cases like that. Again, make sure you talk to your physician before you do that. A lot of people try to self-adjust their medications, and we want to make sure that we're not doing anything that's going to be detrimental to your health.
So we have another question in the chat here. Are you familiar with Valsartan and the recall a couple of years ago? Is that still in effect?
So Valsartan is a blood pressure medication, and it's pretty useful and beneficial. A lot of times when it comes to these recalls, it's usually a particular batch that gets recalled, not the whole entire medication as a whole. So anytime there's a recall, make sure you talk to your pharmacist, and they can look up what serial number, what batch you had, and see if you got the affected batch. If you did, then yes, you probably want to discontinue that. If you are not affected, then you probably can continue with the medication. Of course, there's studies that come out that say, hey, we think there's a link between this type of cancer, this type of condition with certain medications. In those instances, we usually recommend de-seeing those as well too. But when it comes to a generic recall, you want to talk to your pharmacist and see if you got that affected batch before you stop it.
Thank you. Okay, so we don't have any more questions in the chat, and I want to be respectful of time. It is 3 o'clock. The last thing that I would like to ask you is if you could give one last statement or one last piece of advice to the group, kind of what you would like them to take away from today's presentation.
I think the biggest thing is, most people do not like to come to the cardiologist, and I don't blame them. Your heart is something that's very serious. But, these are things that are preventable. And so we as doctors, I think a lot of the times people think that we, just want to push medications or just want to, do whatever is comfortable for us, but make sure that you're with a physician who is actually going to work well with you, has your goals of mind of your healthcare involved as well. And all of these things are preventable. So we can work with you. We can make sure this is preventable. If you have a heart disease, I don't want you to think that this is the end. There's things that we can do to prevent this and to treat this. And also make sure you're being an advocate for yourself. So especially for women in particular, their diagnoses get delayed. We want to make sure if someone does not believe you, you keep on going to whatever doctor you need to go to who will believe you and who will listen to you.
Well, thank you so much for taking the time to be here today and give this presentation, answer our questions. For those of you who are still here, if you have any more questions or comments that maybe you think about after the presentation, you can definitely email us at healtheducator@thewomensfund.org. I will be sending out a survey link following the presentation. So if you could please take that survey, let us know how we're doing, things that we can improve, topics that you're interested in. We would greatly appreciate that. We have a few presentations coming up. At the end of the week, we have a heart health presentation with the Women's Fund. Next week, we'll be covering physical activity. On the 2nd, it's not listed here, but our COVID-19 vaccine presentation has been rescheduled for March 2nd from 1 to 2 p.m. It is up on our website if you're interested in registering for that, learn a little bit more about the COVID-19 vaccines. And then we have a few other presentations, another heart health presentation with a trainer. We have shopping on a budget and mental health and nutrition. On the left-hand side, we have our social media pages and our website. I highly encourage you to go check those out. But that is all that I have for you today. And I want to thank you again, Doctor, for taking the time to be here and give us this wonderful presentation. It was very informative, and I hope you all have a great rest of your day.
Thank you so much. Hopefully I'll be back with you guys again in person soon.
Yes,
Thank you,
hopefully.
Doctor. Very informative.
Thank you
All
very
right.
much.
Thank you.
Good job.
We love you. Bye.
Bye.
We love you very